This presentation is on physical examination skills and clinical diagnosis for the peripheral nervous system. The examination of the nervous system may be broken down into manageable components for ease of learning. However, the student must always bear in mind that whenever assessing the peripheral or central nervous systems, or to an extent the musculoskeletal systems, they are all integrated in many physiological and anatomical ways. In this, the first of two parts of the neurological examination, we will go through the examination of the peripheral nervous system. Part 2, which is on a separate presentation, deals with the examination of the cranial nerves. It is recommended that you revise the relevant anatomy, physiology, and common conditions in order to draw maximum benefit from this video. Throughout this video, I will attempt to cover key anatomical components of the areas being examined. Let us now have a look at some gross anatomical features of the spinal cord. The spinal cord is located within the bony confines of the vertebral canal. It starts from the medulla oblongata at the level of C1 and ends at the level of L1 as the conus medullaris. From L1, the coda equina, which is made up of spinal nerves, continues until it terminates at the coccyx as the filum terminale. The spinal cord is covered by three meningeal membranes. From outermost, these are the dura mater, arachnoid, and pia. The dura is made up of tough, fibrous connective tissue. It continues as the epineurium of the emerging spinal nerves. The middle covering, the arachnoid mater, is a thin, delicate serous sac made up of a visceral and a parietal component. The subarachnoid space contains cerebrospinal fluid, which communicates with the cerebrum via the fourth ventricle. The innermost covering is the pia. This is another vascular layer which closely adheres to the spinal cord. It also gives rise to the denticulate ligaments which extend transversely to suspend the spinal cord within the dural sheath. When looking at the transverse section of the spinal cord, a characteristic grey-color butterfly shape is seen in the center, surrounded by a whiter area. The grey matter is mostly made up of neuron cell bodies, dendrites, synapses, and neuroglial cells. The white matter is made up of myelinated axons. The ventral grey horn contains the cell bodies of the efferent or motor neurons. The dorsal grey horn is made up of cell bodies and synapses from the incoming sensory or afferent fibers. The lateral grey horn is visible only in the thoracic and upper lumbar sections of the spinal cord. These give rise to the sympathetic nerves of the autonomic nervous system. The ventral and dorsal nerve roots of each segment unite within the intervertebral foramina to form mixed spinal nerves. Just outside the bony vertebral column, the spinal nerves divide into a large ventral and a smaller dorsal primary ramus. The ventral primary ramus innervates the larger ventral body regions, and conversely, the dorsal primary ramus innervates the dorsal body regions. There are 31 pairs of spinal nerves: 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. There is also 1 spinal accessory nerve, which is part of the 11th cranial nerve. Blood supply to the spinal cord is by 1 anterior and 2 posterior spinal arteries. The anterior spinal artery supplies the anterior 2/3 of the spinal cord. The 2 posterior spinal arteries supply the posterior 1/3 of the spinal cord. There is additional blood supply from each segment by the radicular or nerve root arteries, which form anastomosis with the spinal arteries. Let us now briefly review the brachial plexus and its principal peripheral nerves, their nerve root values or origin, their course and distribution. The brachial plexus is made up of contributions from C5 to T1. It gives rise to a number of mixed peripheral nerves which supply the upper limbs and shoulder regions. Starting from superiorly, of major clinical significance are the musculocutaneous, axillary, radial, median, and ulnar nerves. The musculocutaneous nerve arises from C5 and C6. It innervates coracobrachialis, biceps brachii, and brachialis muscles. These muscles are associated with elbow and shoulder flexion. The musculocutaneous nerve gives off a branch, the lateral cutaneous nerve of the forearm, which supplies sensation to the lateral part of the forearm. The axillary, the shortest of the major nerves, arises from C5 and C6. It supplies the deltoids and teres minor. They perform abduction and external rotation of the shoulder respectively. The axillary nerve also supplies sensation to the skin over the deltoids, and in particular an area superiorly and laterally over the arm. The radial nerve arises from C5, C6, C7, and C8. It supplies the triceps brachii and extensor muscles of the arm and forearm. These muscles perform extension of the elbow and the hand. The radial nerve also supplies sensation to the skin over the posterior arm and forearm, the posterior and lateral 2/3 of the hand, and proximal parts of the first 3 fingers. The median nerve arises from C5, C6, C7, C8, and T1. It supplies most of the flexor muscles of the forearm. It also supplies sensation to the skin of the lateral 2/3 of the palm of the hand and fingers. The ulnar nerve is the most medial and originates from C8 and T1. It supplies the flexor carpi ulnaris, flexor digitorum profundus, and most of the intrinsic muscles of the hand. The intrinsic muscles are associated with abduction and adduction of the digits. The ulnar nerve also supplies the skin over the medial 1/3 aspect of the hand, the little finger, and the medial part of the ring finger. The lower limbs are supplied by a number of peripheral nerves originating from the lower lumbar and sacral segments. From the lumbosacral plexus of clinical significance are the sciatic and femoral branches, and to a lesser extent the lateral cutaneous nerve of the thigh, the obturator, and the superior and inferior gluteal nerves. The femoral nerve arises from L2, L3, and L4. It supplies the iliacus and quadriceps. These muscles perform hip flexion and knee extension. The femoral nerve also supplies most of the skin over the anterior and medial thigh and the medial part of the leg and ankle. The obturator nerve also arises from L2, L3, and L4. It supplies the adductor muscles of the leg. It also supplies sensation to the skin in the medial aspect of the thigh. The sciatic nerve arises from L4, L5, S1, S2, and S3. It is made up of 2 parts, the tibial and common peroneal nerves. It supplies the muscles of the posterior compartment of the thigh and leg associated with extension of the hip, flexion of the knee, and plantar flexion of the foot. It also supplies sensation to the skin over the posterolateral part of the leg and most of the plantar, dorsal, and lateral parts of the foot. The lateral cutaneous nerve of the thigh arises from L2 and L3. It also supplies the skin of the lateral, posterior, and anterior parts of the thigh. Before proceeding with the clinical examination, let us ensure that you understand the distinctions between the clinical manifestations of upper and lower motor neuron lesions. Somatic or voluntary movement is initiated in the precentral gyrus of the motor cortex of the frontal lobes and relayed to the muscles by the cortical spinal tracts. 2 sets of neurons are needed to convey this neural impulse. The cell bodies of the upper motor neurons start from the primary motor area. The axons travel down to the medulla oblongata, where most cross over to the opposite side and follow the lateral corticospinal tracts. The rest remain ipsilateral in the anterior corticospinal tracts and cross over to the opposite side near their point of exit. At this point in the anterior grey horn, they will synapse with the second or lower motor neurons. The lower motor neurons will take the impulse to the muscles. A lesion such as compression, demyelination, or trauma, depending on its location, may affect the upper, lower, or even both sets of motor neurons. Lesions of upper motor neurons will produce increased muscle tone, pyramidal weakness, that is, weakness in the extensors of the arms and flexors of the legs, increased reflexes, absent abdominal reflex, an upgoing plantar reflex or Babinski's sign, and Clonus. Lesions of lower motor neurons will produce decreased muscle tone, reduced or absent reflexes, muscle weakness, early wasting of the muscles affected, and fasciculations. Examination of the peripheral nervous system can be divided into several components which have a degree of logic and procedural structure. By following this structure, you ensure that you do not omit any areas. The procedure is performed in a logical manner, which starts from observation and finishes with the focal examination of specific components. Assessment of the peripheral nervous system and the musculoskeletal system share a large overlap area, and as it will become apparent, this is inevitable. Classically, the examination of the peripheral nervous system is divided into the following areas: general observation, that is, assessment of posture and gait; close inspection of the body and muscle palpation; active movements; power, coordination, reflexes, assessment of the sensory modalities, and special tests. Let us begin with general observation. It is recommended that the patient is undressed down to their underwear, and if possible, ask them to stand unaided whilst you begin your observation. Observe the patient from the front, sides, and back. Note any abnormalities in posture. Does the patient stand straight, or are they deviating to one side? Could this be due to a musculoskeletal problem, or is it brought on by some defect in the peripheral or central nervous systems? For instance, is the patient standing with feet wide apart, trying to compensate for postural imbalances? Let us now assess posture. Ask the patient to stand with feet close together and note their posture and how steady they remain. Now perform Romberg's test. This test assesses the patient's joint position sense and proprioception without aid from visual input. Ask the patient to keep their feet together and their hands outstretched in front of them. Then ask them to shut their eyes for a few seconds. Reassure them that you will be near them in case they become unstable and fall. In a positive Romberg's test, when the patient shuts their eyes, they become very unsteady on their feet or they fall. It signifies poor joint position sense. Next, we assess their gait. First, ask the patient to walk down to the end of the room and then back. Note the way they walk. Then ask the patient to repeat this, but this time get them to walk heel to toe. Tell the patient to try to walk by placing each footstep in front of each other as if they are measuring the floor. Ask them to look ahead and not at their feet. By observing their gait, attempt to evaluate the following. Are they walking with feet wide apart? Do they sway from side to side? Are they limping? Does walking cause pain? Do they initiate the movement normally? Do they drag their toes? Are they taking small shuffling steps? And can they manage without looking at their feet? Remember that movement requires the coordination of the peripheral and central nervous systems, the basal ganglia, the cerebellum, the vestibular and the musculoskeletal systems. Abnormalities in gait may be attributed to one of these broad categories: neurogenic, musculogenic, arthrogenic, vasculogenic, and antalgic gait. For instance, neurogenic causes of abnormal gait include peripheral neuropathies, Parkinson's, nerve root compression, and many others. Musculogenic include myasthenia gravis and muscle spasms. Arthrogenic causes include an arthritic hip or knee or a short leg. Vasculogenic causes include occlusion of the peripheral vessels. Antalgic gait refers to a posture or gait assumed by the patient in order to avoid or lessen pain. Any number of problems in the above areas may cause the manifestation of a particular change from normal gait. For instance, the dragging of the toes or foot drop is seen in sciatica and S1 nerve root compression. Walking with a poorly flexed hip and circumduction is often seen in someone with severe hip arthritis. Acute weakness and easy fatigue is seen in someone with myasthenia gravis. As you see, it is impossible to stay within the artificial boundaries of a system. In assessing the peripheral nervous system, you will need to bear in mind how disorders in other systems may produce effects similar to a neurological manifestation. If you think you need to assess the strengths of their dorsiflexors or plantar flexors, ask them to take a few paces on their heels, then on their toes. They may need to hold onto your arm for balance. During the above maneuvers, you should be trying to differentially diagnose their different etiologies. Is it muscle weakness or is it peripheral nerve or nerve root involvement? If symmetrical, think of disseminating conditions, peripheral neuropathies, multiple sclerosis, Parkinson's, and motor neuron disease. Don't forget, of course, the functions of the vestibular system and the basal ganglia and the cerebellum. It is beyond the aims of this presentation to cover each of these areas, but it is essential to revise the relevant pathologies and their clinical manifestations. Finally, in this part of the observation, ask the patient to squat down to their heels as far as they can, and then stand up. This tests their ability of the proximal muscles of the lower limbs to perform and control the downgoing and upcoming phase of these movements. They may also reveal musculoskeletal anomalies within the hips, knees, and ankles. Any positive findings during these general aspects of the examination may help you later on to focus your examination into the suspect area. The next part of the examination is close inspection of the body and general palpation. For this part of the examination, the patient should be lying supine and at 45 degrees. Start by observing the general appearance of the patient. In particular, inspect the symmetry, size, and shape of major muscle groups, the joints and limbs. Look for any involuntary movements or spontaneous contractions, such as fasciculations, myochemia, and twitches. Note especially any atrophy or hypertrophy in the involved muscles. Note any deformities and evidence of injuries, including minor bruising, scars associated with operations or trauma, and inquire about this. Before you palpate, to obtain a proper assessment of tone, the patient must be lying comfortably and be warm. Assess the muscle tone, gently squeeze the major muscle groups, and feel for flaccidity, hypertonicity, or spasticity. Be aware of any palpable involuntary movements. At the same time, also assess the skin color, temperature, and hydration. Do this in a systematic way, starting from superiorly, and simultaneously compare side to side. Next, passively assess the movements of the limbs and joints. While you're performing these maneuvers, encourage the patient to relax and not to try to assist you. Evaluate the quality of movements and range achieved. Flex, extend, abduct, adduct, and rotate the shoulders.
And now this one.
Flex and extend the elbows. Flex, extend, and rotate the wrists. Then move to the lower limbs. Flex, extend, and rotate the hips. And now this one. Let it go up as far as you can. That's good. Flex and extend the knees. Dorsiflex, plantar flex, and rotate the ankles. Continue assessing the muscle tone and rigidity. Lift each arm by the elbow and allow it to fall freely. Similarly, lift each leg from under the knee and again allow it to fall freely. Then rock each leg from side to side, noting the presence of undue rigidity in the muscles and joints. Rigidity can be described as clasp knife, the type found with focal upper motor neuron lesions, lead pipe or plastic rigidity observed with Parkinson's where there is widespread muscle rigidity, and cogwheel, again seen in Parkinson's, brought about by superimposed tremor. Next, we assess the active movements. If the patient is bed confined, perform these as they're lying down, otherwise get them to sit or stand up. Ask the patient to move their limbs in all their normal planes of movement, noting the range achieved and control. It is much easier if you demonstrate to the patient what you want them to do rather than issue complex or technical instructions. Start from the shoulders. Ask them to flex and extend them. And now back down and backwards like that. That's good. Now put your hands by your sides and raise them up and over your head again, like so. Then get them to abduct and adduct their shoulders. Then get them to try and touch the back of their shoulder blades from above and then from below. And now can you try and touch your shoulder blades from behind, like so? And now the other one. Good. Now put your elbows by your sides. Okay. And can you rotate your hands out like that? And in. Next, get them to keep their elbows by their sides with their palms facing up and ask them to flex and extend their elbows. Then, with the elbows in the same position, ask them to rotate their forearms. Next, assess their active movements of the lower limbs. Whilst lying down or standing up, ask them to flex and extend their hips and knees. Hold it well. That's good. And now, can you rotate your foot inwards and now outwards, like so? Good. And now put it down and do the same with the other leg. Bend it all the way up. Now rotate your foot this way and now the other way. And now put it down. Now can you point your toes now? Now their ankles. Ask them to push their foot up and then point their toes down. Now assessment of power. Before proceeding, here are some important points. Relate the patient's power to their age, state of health, and physical fitness. Reduced or total loss of power may be confined to a particular group of muscles or to a type of movement. Reduced or total loss of power may also be generalized, affecting more than one area. It may be bilateral and symmetrical. To make a meaningful assessment, you need to compare side to side. You need to ascertain whether loss of power is due to a neurological deficit, as in nerve root compression, neuromuscular problems, as in myasthenia gravis, or due to an apprehensive patient, for instance guarding against an arthritic or painful joint. There are two basic ways of conducting power tests. The first is to get the patient to contract the muscle whilst you resist the movement through most of its range. This is referred to as isotonic contraction. The second preferred method is to get the patient to contract the muscle, like the biceps, by flexing the elbow, and you attempt to extend the elbow from that position. This is isometric contraction, meaning that the arm does not move during the test. It is recommended that you start proximally and move distally, comparing side to side as you go along. To make a meaningful assessment of your findings, you need to know some basic anatomical facts before you commence. These are the name of the muscle or groups of muscles you are testing, which synovial joint they move and what that movement is called, the peripheral nerve which supplies that muscle or group of muscles, and the origins of the nerve root values of that peripheral nerve. In addition, issue clear instructions. Demonstrating to the patient what you want them to do will prevent confusion. Use modest but firm force. Sustain the contraction for a few seconds, and always compare side to side. Abduction of the shoulder, the deltoids, the axillary or circumflex nerve, from C5. And push up. That's fine, thank you. Flexion of the elbow, biceps brachii and brachialis. The musculocutaneous nerve, from C5 and C6. Good, thank you. Now this one. Again, bend your elbow and don't let me open it. That's fine, thank you. Flexion of the elbow in semipronation. Brachioradialis, the radial nerve, from C5 and C6. That's fine, thank you. Extension of the elbow, the triceps, the radial nerve, from C6, C7 and C8. That's fine. And now this one. Push down. Thank you. Flexion of the wrist, the flexor group, the median nerve, from C8 and T1. And I'm going to resist you, yeah? Okay. That's fine. Now can you push your fist upwards and resist me? That's fine. Extension of the wrist, the extensor group, the radial nerve, from C6, C7 and C8. That's fine, thank you. Flexion of the distal phalanges, flexor digitorum superficialis and flexor digitorum profundus. The median nerve for the first and second finger and the ulnar nerve for the third and fourth fingers. From C7, C8 and T1, but mostly from C8. Extension of the digits, extensor digitorum, the radial nerve, mostly from C7 and C8. Good. Abduction of the fingers. Abduction of the index finger. The first dorsal interossei. The ulnar nerve from T1. Abduction of the little finger. Abductor digiti minimi, also the ulnar nerve, from T1. Abduction of the thumb. Abductor pollicis brevis, the median nerve, from C8 and T1. Now this one. And with your thumb now, push it upwards like so. That's fine. Opposition of the thumb with little finger. Opponens pollicis, the median nerve, from T1. That's fine. Now with this hand now. That's good. Finger flexion, the median and ulnar nerves, mostly from C8. Flexion of the hip, iliopsoas and rectus femoris, inferior gluteal nerve and femoral nerve, from L2, L3 and L4. Bend your hip up like so and try and bring the knee up towards your chest and resist me. Keep your foot off the couch. That's good. And push up. That's fine, thank you. Now the other one. Bend your knee and bend your hip up towards your chest and resist me. That's fine, thank you. Flexion of the knee, the hamstrings, the sciatic nerve from S1 and S2. Push it down. That's good. Now to the opposite. Bend your knee again. What I'd like you to do this time is push your heel towards your buttock and resist me. That's fine. Now the other one. And push down. Don't let me straighten it. That's fine, thank you. Extension of the knee, the quadriceps, the femoral nerve, L2, L3 and L4. When testing for extension of the knee, do not lock the knee as you will be recruiting the popliteus muscle. That's fine. Do the opposite. Push your foot outwards. Now bend your knee and push your foot out and resist me. That's fine. Now bend your knee and push your leg outwards and resist me. That's good. Thank you. Dorsiflexion of the ankle. Tibialis anterior, the common peroneal nerve, the deep peroneal branch, from L4 and L5. That's fine. Now what I'd like you to do this time is push your feet up like so and resist me. That's fine. Good. Plantar flexion of the ankle, the calf muscles, the medial popliteal branch of the sciatic nerve, from S1 and S2. Good. Flexion of the toes, flexor digitorum, the medial popliteal nerve, a branch of the sciatic nerve, from S1 and S2. Extension of the toes and extensor digitorum, the common perineal nerve, a branch of the sciatic nerve, from L5 and S1. Hold your toes upwards and resist me. Just your toes. That's it. That's fine. extension of the big toe, extensor hallucis, the deep peroneal nerve, a branch of the sciatic nerve, from L5. Fine. Hip extension, gluteus maximus, inferior gluteal nerve, from L5 and S1. Also the hamstrings, the sciatic nerve, mostly from S1. To test for extension of the hip, it is preferable to position the patient either supine or prone. Mr. Thomas, what I'd like you to do is raise the whole of your leg straight up, like so, just the whole thing, that's it. And resist me from pushing it down. That's fine, and now this one. Push it up and resist me. That's fine, thank you. To eliminate contribution from the flexors of the knee, ask them to flex their knee first. Up against me and resist me. That's fine, thank you very much. Now put it down and bend this one. Lift it up and resist me. Good. Good. Finally, check for the presence of Clonus. This is sustained involuntary rhythmic contractions when a muscle is stretched. Test for Clonus on the quadriceps by pushing the patella downwards briskly and maintain the force. Alternatively, dorsiflex the ankle and hold in that position for a few seconds. Leave it there, that's fine. And now this one. Bend it slightly. Fine, thank you. The presence of Clonus signifies an upper motor neuron lesion above the level of the root being tested. It is a common sign in multiple sclerosis, spinal cord injury, spastic paraparesis, and other diseases. It is considered normal in newborn babies. Now coordination. In testing for coordination, we are also assessing components of joint position sense and proprioception. There were elements of these modalities when posture and gait was assessed earlier on. For proper, smooth, coordinated movement, the body needs to integrate sensory input from the various sensors within the muscles, ligaments, tendons, and the skin. Proprioception and joint position sense travels through the posterior columns and spinocerebellar tracts to reach the cerebellum and the cerebrum. These modalities, together with visual and vestibular input, are integrated in the cerebellum to facilitate posture and gait. Specific tests can be performed to test for coordination. Ask the patient to stand with their hands outstretched in front of them with their eyes closed, as with the Rombeck's test. Tell the patient to try to keep their hands in that position. Then suddenly push their arms up or down. The arms should return quickly to their original position. Also note their fingers if they are steady or moving in a wandering gesture. If one of the arms is weak, then there will be a displacement, and in cerebellar disease, there will be several oscillations on the affected side. Demonstrate the finger-to-nose test. With their index finger, get them to touch their nose first, then touch your fingertip. Repeat this procedure and change the position and speed of your finger. Okay, and your nose. That's fine, thank you. Another test for coordination is to perform rapid alternating movements with the hands. Ask the patient to beat their own palm by rotating their striking hand, alternating the dorsal and palmar sides each time. As fast as you can. That's good. Now can you alternate the hand now? Inability to perform rapid alternating movements is called didactical kinesia. Explain the heel to shin test to the patient. This involves using the heel of one foot to touch the shin of the other leg, then slide it downwards and near the ankle, lift it up and start the same process again. And try and do it a bit faster. Okay, do that for me, lift it up. Okay, now repeat this process for me. Faster. That's good. Now can you alternate your legs? Swap over. Good. That's fine, thank you. Test for truncal ataxia by asking the patient to sit up from lying supine without using their hands. Observe if the patient deviates or falls on one side. Truncal ataxia is associated with midline cerebellar or posterior fossa lesions. Joint position sense stimuli picked up from the peripheral sensors ascend the spinal cord in the posterior columns. This modality tests the positional awareness of a limb or joint without the help from visual input. Poor coordination is termed ataxia, which is described according to the source of the problem. Remember that cerebellar ataxia causes wide irregular oscillations when movement is initiated. Now joint position sense. Demonstrate to the patient with their eyes open at this stage what you will be doing and what you expect them to tell you. Hold the distal phalanx of the big toe by the sides and with gross movement push it up and then down. Then, when they have shut their eyes, start with small amplitude movement to find out if they can correctly detect the position of the joint. You can repeat this test with one of their fingers.
Down, up, up.
Fine. Now with this one.
Down, up, down, down.
Now, Mr. Thomas, what I'd like you to do. The pronate or drift test can also be performed if indicated. Ask the patient to stand with the hands supinated and stretched out in front of them with their eyes closed. Wait for 20 to 30 seconds. In a positive test, there will be flexion and pronation of the elbow. These may be observed with upper motor neuron lesions, for instance in hemiplegia. We now move on to the next stage of the peripheral neurological assessment with examination of the reflexes. As with the previous section, when testing for the reflexes, you need to know the following basic elements: what the reflex is called, which muscle or group of muscles causes the contraction, what movement you are expected to see, which peripheral nerve supplies that muscle, and the nerve root values of the reflex. Remember that tendon or deep reflexes are monosynaptic arcs involving a sensor, in this case a stretch receptor in the tendon and muscles, afferent fibers which carries this impulse to the spinal cord, a synapse with a motor neuron, and a contractile element, in this case a muscle. Therefore, when testing the reflexes, you're essentially testing the integrity of all of the above structures which are associated with the lower motor neurons. You are also testing the influence of the upper motor neurons and their associations. You should also be reminded at this stage that lower motor neuron lesions causes reduced or absent reflexes, in contrast to upper motor neuron lesions which result in brisk or exaggerated reflexes. Familiarize yourself with the patella hammer and learn to use it properly. A long-handled patella hammer with a large round head is preferable. It allows you to swing it from the end so that you strike the tendon in a swinging brisk motion using momentum rather than force. During all stages of the reflex testing, the patient must be relaxed, warm, and the limb to be tested being completely passive. Talking to the patient helps to distract their attention. If you are unable to obtain a good reflex, use the reinforcement technique. For instance, get the patient to lock their fingers and to try to pull them apart. Alternatively, ask them to clench their fist or to point their toes as you elicit their reflex on another limb. Let us begin with testing the reflexes of the upper limb. For the biceps reflex, semiflex the elbow and place modest pressure with your thumb on the biceps tendon. This is located in the medial part of the elbow crease. When you have tensed the tendon, strike your own thumb. The bicep reflex is supplied by the musculocutaneous nerve, mostly from C5. Now move behind the elbow for the triceps reflex. Take care not to strike over the medial aspect of the olecranon in case you hit the sensitive and occasionally exposed ulnar nerve. The triceps reflex is supplied by the radial nerve, mostly from C7. For the supinator reflex, place the forearm in a semi-pronated and semi-flexed position. Place your fingers or thumb on the distal part of the radius just above the styloid process and strike your own fingers. You may also strike the tendon directly, but take care not to cause any pain. The supinator or brachioradialis reflex is supplied by the radial nerve, mostly from C6. Finger flexion, the median and ulnar nerves, mostly from C8. Hoffmann's reflex is elicited by quickly flicking down the distal phalanx of the middle finger and observing for a reciprocal grasp-like motion of the other fingers. If present, it signifies an upper motor neuron lesion affecting the related limb. Now the tendon reflexes of the lower limbs. These may be elicited either in the sitting or supine position. For the knee reflex, fully support the weight of the semi-flexed knee and strike the patellar ligament between the patella and the tibial tuberosity. The knee reflex is supplied by the femoral nerve from L3 and L4. The ankle reflex can be elicited either in the sitting position or lying supine. In all positions, you will need to dorsiflex the foot, thus placing a stretch on the Achilles tendon and calf muscles. Ensure that at all times the patient remains passive by not trying to assist you. In the lying position, rotate the hip externally and slightly flex the knee, thus exposing the Achilles tendon. Dorsiflex the ankle and strike the Achilles tendon directly. The other method in this position involves placing a stretch through the Achilles tendon by dorsiflexing the patient's foot, then striking your own fingers. To test the ankle reflex in the sitting position, dorsiflex the ankle and then strike the Achilles tendon from behind. The ankle reflex is supplied by the medial popliteal nerve, mostly from S1 and S2. To elicit the jaw reflex, ask the patient to relax the jaw or to keep it slightly open. Position your finger over the mandible and strike it. An exaggerated jaw reflex may be associated with suprapontine lesions. After assessing the tendon reflexes, then move on to the plantar, abdominal, cremasteric, and anal reflexes. These are also referred to as superficial or cutaneous reflexes. When eliciting the plantar reflex, you observe for the reaction of the toes to a superficial stimulus that is induced from the sole of the foot. A positive plantar reflex, or Babinski's sign, is extension of the hallux and fanning out of the other toes. A positive plantar response signifies an upper motor neuron lesion above the S1 spinal segment. A normal response would be flexion of the toes, or in some individuals there may not be any observable reaction. Do not confuse a withdrawal reaction of the whole foot because the patient finds the test unpleasant or ticklish. To induce the reflex, use the tip of the handle of the patella hammer or the back of an orange stick. Apply firm pressure to the lateral border of the plantar aspect of the foot in a curved or crescent direction, starting from the sole of the foot and move towards the toes. Remember that in children under 2 years of age, an upgoing plantar response or a positive Babinski sign is a normal manifestation. Now test for the abdominal reflex. Lightly draw the end of a pointed but not sharp instrument across the 4 quadrants of the abdomen. You can use an orange stick or the pointed end of the patella hammer. Avoid scratching the patient's skin as the abdomen is a tender area. A normal reaction would be contraction of the abdominal muscles. Remember that the umbilicus is supplied by T10. The area tested above the umbilicus is approximately 2 dermatomes higher, that is T8 and T9, and the area below is 2 dermatomes lower, that is T11 and T12. An absent response signifies a corticospinal tract lesion above the corresponding spinal segment. An absent abdominal reflex may also be found in the obese, with previous abdominal operations, in the very old, and those who had multiple pregnancies. The cremasteric reflex is elicited by striking the superior and medial area of the thigh just next to the testicles. A normal response will be the contraction of the cremaster muscle on the same side, causing elevation of the testicle. Repeat the test on the other side. If your examining room is cold, then it will be difficult to observe the contraction, as the skin of the scrotum will be gathered. Due to the embryonic development of the gonads, the cremasteric muscle is innervated by higher lumbar segments, that is from L1 and L2. An absent cremasteric reflex may signify a corticospinal tract lesion above L1, a lesion in the reflex arc, or local surgery. It is often absent in multiple sclerosis. For the anal reflex, place the patient in the Sims position and expose the anal area. Using an orange stick, place a gentle scratch near the anal orifice, thus stimulating a contraction in the external sphincter. This area is innervated by the lowest sacral segments, that is from S4 and S5. Central core compression or coda equina syndrome will cause an absent anal reflex. The next stage of the examination is assessment of the sensory modalities. Let us briefly review the dermatomes and in particular of the upper and lower limbs. These are always displayed in the anatomical position. Note the key dermatomes of the upper limbs. Start from C5 over the shoulder region until T2 near the medial aspect of the axilla. Note the thumb is from C6 and the little finger from C8. The umbilicus is from T10. In the lower limbs, note the L1 dermatome, which is over the superior part of the thigh anteriorly, and then progress inferiorly until S2 dermatome in the posterior aspect of the thigh. Note the knee is from L3, the big toe from L5, and the small toe from S1. When performing a sensory test, we assess for the sensory modalities of light touch, pain, vibration, and temperature. The reason for testing different modalities is to assess the integrity of the receptors, the peripheral nerve, the ascending long tracts in the spinal cord, and their cortical interpretations. We begin by testing for light touch. Use a twisted piece of cotton wool. Ask the patient to shut their eyes, then either to tell you the location where they are being touched or just to say a simple yes. Aim to test most of the dermatomes, particularly in the upper and lower limbs. Testing should be done in an unpredictable manner rather than in a linear progression. Touch lightly and avoid pressure or dragging the cotton wool across adjacent dermatomes. This motion will also stimulate the hair follicles.
Right arm. Left leg. Right leg. Right leg. Left leg. Left leg. Right toe. Right leg. Right leg.
Now test for pain using a clean pin, preferably a neuropin. Never use a hypodermic needle or a previously used pin. Demonstrate to the patient what you're going to do and what is expected of them. First, with their eyes open, choose a sensitive part on their body to demonstrate to them what a sharp and a dull sensation should feel like. Now tell the patient to shut their eyes and begin testing. Paying particular attention to clinically important dermatomes or suspect areas. Test in an unpredictable fashion using mostly the sharp end of the pin and less the blunt end.
Dull. Sharp. 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 Dull. Sharp. 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 Sharp.
Okay, now I'm going to do the same on your legs.
Sharp. Dull. Sharp. 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 Dull. Dull. Sharp. Sharp. Dull. Sharp. Sharp.
If you discover an area where pain sensation is reduced, try to map out the area by testing from the center of this area outwards towards the intact area. Also, ascertain whether the affected area conforms to a dermatomal or peripheral nerve distribution. Don't forget to take into consideration variation in skin thickness, as this will affect the degree of sensitivity. Testing for vibration is another important and yet simple way of investigating neurological disorders. In conditions like peripheral or diabetic neuropathies, reduced vibration sense is often one of the earliest presentations. But remember that vibration sense declines with age, so take this into account when examining. You need to use a tuning fork of 128 Hz frequency. Testing should always commence from the most distal parts of the upper and lower limbs. It is advisable to demonstrate first what they should be expected to experience by placing the vibrating tuning fork on their sternum. Strike the tuning fork gently on a firm surface or pinch the prongs with your fingers to start the vibration. Hold it from just above the base. Ask the patient to shut their eyes and press the base of the tuning fork firmly on a bony prominence. Start from the bony part of the big toe. If they can feel the vibration properly over both sides, then there is no need to test more proximally. If vibration sense is reduced or absent, then test over the malleoli, then to the patella of the knees, then move up to the iliac crests if necessary. Perform the same routine in the upper limbs, starting from the fingers. If vibration sense is absent, then move to the wrists, then to the elbows. We now move on to the assessment of temperature sensation. Although this is not routinely performed, it can be a useful neurological test. Remember that temperature sensation is conveyed in the spinal cord in the lateral spinothalamic tracts. For this, you will need 2 test tubes. Fill one with very warm water, but not hot, as this will stimulate pain receptors. The other fill with very cold water. In an intact and sensitive part of their body, demonstrate what a hot and cold sensation should feel like. Ask the patient to shut their eyes and start by testing one side of the body first. Apply one of the tubes, then the other one. Then apply both tubes at different parts of the body simultaneously. Is the patient able to differentiate between the hot and cold tubes? Which one is hot and which one is cold?
Okay. The lower one's hot. Top one's cold. Top one's hot. Lower one's cold.
Fine, thank you. You can open your eyes now. Other additional sensory tests are 2-point discrimination, graphesthesia, and stereognosis. 2-point discrimination now. It involves the ability to tell how sensitive you are to two separate stimuli at close distance. For this test, you will need to use a 2-point discriminator, a double-ended pin, or improvise with a paper clip. Ask the patient to close their eyes and test by starting at the fingers at a distance of, say, half a centimeter apart. Less sensitive parts of the body, such as the trunk, cannot detect the 2 points unless you increase the distance between the pins. Fine, now give me the other hand, please. Now repeat the same again. Now close your eyes.
2. 2. 2. 2. 1.
Fine, you can open your eyes. Stereognosis is the ability to tell what the object you are handling is without looking at it. This is achieved from the feel of its texture and shape and from having previously come across the same object. Ask the patient to shut their eyes and give them a familiar object to handle.
50p piece.
Thank you. And now?
Pen top.
That's good. Now, can I have your other hand, please?
Pen top. £50p piece.
Good.
Paperclip.
Fine, you can open your eyes now. Graphesthesia is the ability to recognize a number or a letter being inscribed in the palm of the hand. Use a pointed instrument like the end of an orange stick. Again, the patient keeps their eyes closed when the figure is drawn in the palm of the hand.
F.
That's fine. Can I have your other hand?
R.
Good.
Z.
That's fine, thank you. 2-point discrimination, stereognosis, and graphesthesia are conveyed in the posterior columns. Let us now cover some additional special tests. There are a number of physical tests which have been devised to test for certain conditions or syndromes. The straight leg raising test. This particular test checks for the nerve root impingement in the lumbar and higher sacral segments. The patient lies supine and one of the legs is slowly lifted from the ankle by keeping the knee straight. If positive, as their leg is elevated, the patient will complain of increasing back pain, leg pain, or neurological disturbance in that or even the opposite leg. This pain is caused by the traction of the nerve roots by the pull from the sciatic nerve. A normal leg should be lifted free of pain up to 90 degrees, but take into account the patient's physique and age. Discomfort due to tight hamstrings should not be considered as a positive test. A positive test is often associated with an intervertebral disc prolapse or any other condition which causes impingement or inflammation in the intervertebral foramen. The femoral nerve stretch uses the same principle as with the straight leg raising test, but now we stretch the femoral nerve by extending the hip. The patient needs to lie on the non-affected side, then slowly start extending the symptomatic thigh. In a positive test, the patient will complain of pain in the lumbar region or neurological symptoms in the thigh. The meningeal stretch test, or Koenig sign, assesses for irritation of the meningeal membranes of the spinal cord, especially in a patient with neck stiffness. From the supine position, the hip and knee are flexed, and then the knee is gradually extended. A positive Koenig sign is bilateral resistance and pain on extension of the knee. The pain may also be experienced throughout the spinal cord. If the symptoms are unilateral, then these may indicate a radiculopathy in the lumbar region, such as straight leg raising test. Do not confuse simple tightness and discomfort from the muscles and the tendons. Another method for testing for meningeal irritation is to assist the patient to elevate their head off the pillow. By doing so, you are inducing flexion in the neck and thus stretching the meninges. If positive, there will be resistance and generalized pain in the neck spreading down the spinal cord. The patient will try to flex the hips and the knees in an attempt to reduce the pain. This phenomenon is also known as Brzezinski's sign. Lermy's test is the feeling of electric shock running down the neck and the back, or even in all four extremities. Forward flex the patient's neck to see if you can provoke this sensation. This finding often indicates demyelination, as in multiple sclerosis. It is also seen more seldom in cervical myelopathy, cervical tumors, in B12 deficiency leading to subacute combined degeneration of the spinal cord, and in whiplash injuries. Lermy's phenomenon can also be tested with neck extension. It may also occur spontaneously. Tinol's test is used to evaluate compression or inflammation of a vulnerable peripheral nerve. Using your fingers or the tendon hammer, briskly strike the suspect area. It is often applied over the flexor retinaculum to test for carpal tunnel syndrome. A positive test will produce paresthesia or pain in the distribution of that nerve. How was that?
Okay. Fine.
Good. Can I get you to bend your elbow like so? Just bend your elbow, that's it. Do you have any pain or tingling or anything in your hand?
Nothing in there at all.
And now your son, just bend your elbow like that. And how was that?
That's fine.
Fine. Thank you very much. We have now concluded the procedure for assessing the peripheral nervous system. Let us now retrace the main steps. General observation, assessment of posture and gait, close inspection and muscle palpation, passively assess the movements of the limbs and joints, active movements, power, coordination, reflexes, assessment of the sensory modalities, and special tests. Assessment of the cranial nerves is covered in a different presentation.